Hi, welcome back to Student Nurses Success, where we're continuing our series on skin conditions and integumentary disorders. This particular map is going to talk about infectious disorders. So we're going to talk about bacterial infectious disorders, yeast or candida, fungal, viral infections, and we're going to throw acne in there as well. Acne kind of crosses over between bacterial and inflammatory, but we're going to go ahead and put it in on this map. So remember, you can find a link to the maps in the comments section. Let's go ahead and get started. Let's first begin and talk about bacterial skin infections. We're talking about bacterial skin infections. There's two in particular that I want to talk about. One is impetigo and one is cellulitis. Now, impetigo is a little bit more superficial. So we're looking at really just the infection is on the top layers of the skin. So it's not quite as serious as cellulitis, but it's certainly contagious and can cause scarring and is something that does need to be treated. So impetigo is a secondary superficial skin infection and usually comes after there's been some little topical break to the skin. Sometimes in children, they get impetigo like under their nose if they have a real runny nose and that runny nose has kind of excoriated that skin, or perhaps there's been moisture around their face or their lips where they're drooling and it kind of has altered that skin integrity. You could get impetigo maybe from shaving your legs if with a dirty razor, where you're just kind of getting this topical skin infection. You'll know you'll have impetigo because you would see some vesicles, which is some little kind of tiny little papules that maybe have a little fluid in them, maybe even pustules with a little bit of pus in them. And then as those kind of crust and break, they look like honey crusted lesions. So they're kind of a yellow honey color and they make these crusty lesions. Staph or strep is usually the causative agent of either. You have a lot of that on your skin. So let's look at a picture of, let's see here. Where did I hide impetigo? Oh, there we go. So, oh, that's not real clear, but you can kind of see here impetigo on this individual's leg. So you kind of see this yellow crusty stuff right there with that purulent drainage. Now, cellulitis is very serious and it's an infection down in the subcutaneous layers of the skin, so it's deeper. Usually see it often from maybe a bug bite or a wound that has been infected, but I would say bug bites for sure are a big one. Um, it is more serious, it is painful, and you get a much bigger inflammatory response. So you get a lot more redness. The area will become red and swollen, warm to touch or hot, and patients may even develop fever or chills because it's in that subcutaneous tissue. We know that there's a higher risk of cellulitis in those who have decreased circulation because they have maybe poor blood flow to that area. They do not heal as well. If we look here, you can see a real hot case of cellulitis. And what they've done here is you'll see some markings on their skin where the nurses or the providers have actually marked the areas to see if that redness is growing. But it looks very, very hot, very, very painful. It's a very serious condition. Now let's move on up here and talk about yeast candida infections, which is really just an overgrowth of candida or yeast on mucous membranes or the skin. If it's in your mouth, we call it thrush. We'll see white lesions in the mouth, or it may be thrush in the vaginal region as well. Sometimes we see yeast growing under skin folds, and it can be kind of an irritant and cause a dermatitis in areas where maybe you have a lot of skin touching skin. Perhaps an individual who has maybe large breasts or they have some extra skin folds, they can get yeast growing in between those skin folds. We call that intertrigo. We see here, I just have a picture of thrush. I didn't get you a picture of intertrigo, but you could Google that and get a picture of that. But you see these white patches in the mouth, and so that would be thrush. But you could also see that in the vaginal area as well, and we would consider that thrush also. Let's talk about superficial fungal infections next. So we have fungal infections, and sometimes we call these mycotic infections. The mycotic infections we are often referred to as the tinnias as well. So there you go, three different names for about the same thing. These are mycotic or fungal infections that are superficial. So they're just growing on the outer layers of the skin. If you get fungus deep in your subcutaneous tissue or in your bloodstream or down in your organs, that is a very, very serious condition. These we're talking about aren't quite as serious. They're tinnias. They're just superficial mycotic or fungal infections on the skin. They are contagious and they are spread from skin to skin contact. They thrive in warm, moist environments and they just infect that top layer of skin or maybe even nails. They produce a red, itchy rash. And we call them different things depending on where they're located. So, tinea capitis would be on the scalp, and sometimes we refer to that as ringworm of the scalp. Tinea barbas, maybe in the beard area on the face. Tinea corporis is on the trunk, and we often call this ringworm. Tinea cruris is in the groin, or it's sometimes called jock itch. Tinea pedis, often called athlete's foot, in the foot region. Certainly your feet are nice and warm and moist. And onychomycosis is if it's in the nail. And that is actually really hard to treat. That one's going to take, a good 6 to 8 weeks of an oral antifungal to really get down into that nail. These others usually respond to topical types of treatments, except for tinea capitis, which is probably going to need oral as well because the hair and the nail are kind of hard to kind of kill that fungus, but the other ones are more superficial. So I have a couple pictures here. This one is Tinea corporis. So that's ringworm of the body. You see these very characteristic kind of red areas, and they have this central clearing. And here we have Tinea capitis or ringworm of the scalp. And usually the hair will actually fall out in those areas. Let's move on to our viral infections. We have quite a few here that we're going to kind of talk about. The first one is warts. Warts are caused by the papillomavirus. There are hundreds of strains of papillomavirus. Some are oncogenic, meaning they can cause cancer. So HPV, we know in the genital area is high risk for developing cervical cancers. What you see with warts is just what you think you see. Irregular thickening of the strata corneum. So you see these little outcroppings. They kind of sometimes look like little cauliflower buds. They can be on the fingers. They could be anywhere on the body. Sometimes they will resolve spontaneous and they'll just go away. Sometimes we have to have them removed because they're maybe large or getting in the way. If you have them burnt off with or frozen off, sometimes they will return, sometimes they stay away. So it just kind of depends with warts. Herpes simplex virus, there's two types, HSV1, HSV2. HSV2 is usually below the waist in the genital area. It's a sexually transmitted disease. HSV1, we know, is above the waist. It's more cold sores on the face, lips, or mouth. Now, both of these the HSV1 can show up down below the waist, and HSV2 can also show up above the waist, depending because they are transmitted by contact. Often they start as little vesicles that kind of pop and turn into ulcerations, and they may get little crusts on them. Um, when they start to erupt, they patients usually talk about a burning or tingling sensation before they develop, so they kind of know they're coming on. They can be a primary infection, meaning you've never had it before, or once you have a primary infection, then you get recurrent flare-ups of it. And those flare-ups kind of come and go. They have exacerbations and remissions. There's really no cure for HSV. We can give you meds to kind of calm down those outbreaks, but it's not really curable. We can just kind of keep it a little bit more under control. So the antivirals will kind of shorten the flare-up course, but it's not going to cure it. And I believe I had a picture of HSV1 right here, the cold sores on the lips. Herpes zoster, known as shingles, that is a reactivation of a latent varicella zoster virus or chickenpox. So once you've had chickenpox, sometimes that virus hangs out in your body. Some people can have outbreaks of zoster or shingles, and others may not. So we're just not really sure. The outbreaks of zoster shingles are very painful. So you'll get an eruption of these very painful vesicles. They look like little blisters. They have red bases and they will kind of pop and turn into ulcerations. They will affect along dermatones. So you'll kind of get these kind of swaths of them along the torso in dermatome areas. They will clear in a couple weeks, but until that, new crops come up every couple days for a while. So it's about 2 to 3 weeks after the last crop appears. Now, if you have never had chickenpox and you are not immune to chickenpox and you are exposed to zoster or shingles, you can actually develop chickenpox from that. So those who are not immune to chickenpox can contract chickenpox from zoster or shingles, but it's not the other way around. As far as treatment, because they are so painful, we keep them covered. We can give some antiviral medications to kind of help shorten that course and control it a little bit. There is also a vaccine that is helpful in preventing zoster outbreaks. Here you can see this is zoster. See how it's kind of in this kind of line along the dermatones, and you see these kind of blisteries. Those will kind of rupture and turn into little ulcerations. Now, varicella zoster chickenpox chickenpox is in 3 stages. It starts with a red macule, then it goes to a vesicle or the little blister, tiny fluid-filled little blister, and then those will pop and scab over. So it moves through those 3 stages. Chickenpox usually starts on the torso and then moves out toward the limbs. So you'll kind of start to notice it on maybe their back or their belly. They're very, very itchy, so a lot of pruritus, may have some cold symptoms, malaise, but a lot of times kids feel fine with chickenpox, but it's highly contagious, so they really can't go to school or anything, and we don't see it as much as we used to because of the chickenpox vaccine. We do recommend people get the vaccine because anytime you're going to have all these vesicles and scabbing, it can turn into skin infections. We know there's a risk of developing encephalitis, pneumonia, and even sepsis. So there are some bad outcomes from it, so we don't want to get it. Rubella, or the German 3-day measles, this is a diffuse macular rash, so it's flat and it's just red spots. Patients have cold symptoms and fever. Incubation is about 2 to 3 weeks. The problem with rubella, it is very teratogenic to the fetus. So if the mom is pregnant and contracts rubella or receives a rubella vaccine while she's pregnant, then the fetus can have some very severe congenital defects. So if someone is not immune to rubella, we will wait till they deliver the baby before we give them that immunization. So here I think I have a picture of rubella. It didn't show up real good, but it's just kind of this diffuse red, um, flat rash. And the last of the viral infections is rubeola, or the 7-day measles. Again, you get this macular blotchy rash, similar to the rubella, but in addition, you're going to have this thing called Koplik spots on the buccal mucosa. So there'll be some kind of white bluish spots inside the mouth that are characteristic of 7-day measles or rubeola. Um, Incubation period is anywhere from a week to up to 3 weeks. It is highly contagious. A lot of complications from rubeola, pneumonia, encephalitis, otitis media, or ear infections. And we have a little picture here of rubeola. You can kind of see that diffuse red rash in here. And this did not turn out real well, you can see, but it's kind of how the rash kind of progresses. It's not real bad on these first few days, and then it progresses, and the whole body is just covered. So it's pretty dramatic. And the last is acne. With acne vulgaris, it's bacterial and inflammatory response. So the problem with acne is it's a disease of the pilosebaceous unit or the oil glands, and it's can be non-inflammatory or inflammatory. Non-inflammatory is when you have kind of the black heads and the white heads, but they're not very swollen. They're just kind of little pimples. They're not too bad. Inflammatory is when those get inflamed and turn into papules and pustules and even nodules and cysts. So it's much more dramatic. Their face gets very red, or the areas of the back, maybe that are affected, really get these very painful red, swollen pustules and nodules. And those can really lead to a lot of scarring for individuals. We do know genetics plays a role. Some people just have oilier glands than others. The hormones of adolescence and young adulthood play into that, making lots and lots of oil. And that sludging of the oils and then the loose skin cells really obstruct the follicular canal where the oils are coming out. And it causes a lot of infection and inflammation. Again, we really worry about the scar formation. Plus, it's very uncomfortable to have all these red, inflamed pustules and nodules on your face or on your back. Treatment ranges from topical and oral medications, some topical things to control, but also maybe some oral antibiotics to kind of kill off that bacterial overgrowth that is feeding off of these sludging oils and skin cells. And that about does it. Um, Please stay tuned for our other videos on our other skin conditions. And I hope you have a wonderful day.